Welcome to the deep dive. This is why we take a whole stack of really detailed info on, well, what seems like a tricky subject, and we boil it all down. The goal is so you can get properly informed, fast, and maybe find some surprising stuff along the way. Today, we're jumping headfirst into the dental implant prosthodontics. Sounds complicated, right? But it's this amazing mix of biology, some serious engineering, and honestly, real artistry. It's not just filling a gap. We're going to explore how these things manage to feel like they actually belong there, the natural part of you. This deep dive is really for you to get past the surface level on this incredible field.
Exactly. And our guide for this is a pretty hefty professional text. It's incredibly thorough. Our job really is to pull out the most vital bits, the stuff that might even surprise you, and make it all clear and feel engaging.
Okay, let's start right there, under the surface. Biologically speaking, what's the magic? How does an implant convince the body it's supposed to be there?
Right. So we need to talk about peri-implant biology and something called the biologic width. Think about your natural teeth. They have this protective seal of gum and bone right around the tooth root. It's sometimes called the dentogingival complex. Now, classic studies going way back found this protective zone is usually about 3 millimeters thick. What's really fascinating, though, is that even though the tissues around an implant are built differently, they seem to adapt. More recent work shows they create a very similar biological seal, also around 3 millimeters.
So the body sort of recreates its own pattern around the implant.
Kind of, yeah. And that's why the recommended placement depth for an implant is often, 3 to 4 millimeters below where the gum line starts. That little bit of space, it's absolutely crucial. It lets that biologic width form properly. It also helps the final tooth look like it's emerging naturally, looks good aesthetically, and gives room for the tissues and bone to remodel. That remodeling happens mostly in the first 6 months, maybe up to a year.
So it's all about giving nature the space it needs to work. But does the type of gum tissue someone already has affect that process? You mentioned the periodontium.
Oh, absolutely. It can make a big difference. Think of gum tissue like fabric. Some people have thin, delicate, sort of scallop gums, almost like lace. Others have thicker, flatter, more robust tissue, that thin scallop type. It's much more likely to recede over time, whereas the thicker, non-scallop type is more stable. This is really important for looks, especially at the front.
Okay, that makes sense. And what about the space between things, like implant to implant or implant to a natural tooth? I feel like I've heard there are really strict rules there.
Oh, incredibly strict. And this is one of those, really surprising but fundamental details. There was some pioneering research, Tarnow and his group, that really showed how the bone level dictates the soft tissue between teeth. So for instance, to stop bone loss next to a natural tooth, you really want at least 2 millimeters of space between the side of the implant and that tooth root. But here's the kicker, the really crucial bit, between two implants. If those implant surfaces are closer than about 3 millimeters.
Uh-oh. What happens?
Well, you risk this sort of mutually destructive bone loss. The bone between them just resorbs, it melts away laterally.
Wow. So that 3 millimeter rule isn't just a guideline, it's like a biological necessity. Get it wrong, and you could compromise both implants.
Exactly. It's not just about one implant. It's about the whole system. It underlines how critical that precision planning is for long-term health.
And what about the bone level right around the implant itself? Does it tend to change over time?
A little bit is expected. You might see maybe up to 1.5 millimeters of settling in that first year, year and a half. But after that initial phase, it should become really stable. We're talking very minimal changes, maybe 0.2 millimeters a year on average. That stability, it's actually one of the key signs of a successful implant, something researchers like Albrechtsen pointed out years ago.
Okay, so we've got this amazing biological foundation, how the implant actually becomes part of the jaw. But like you said, that doesn't happen in isolation. It's happening in a person. So let's shift focus. How do the patient's own health, their habits, their specific situation play into whether this all works out?
That's a perfect transition.
Yeah.
Because yes, the patient factors are huge. It's not just about the mouth. Thinking about the soft tissues first, you really need enough of that tough, stable gum tissue, what we call keratinized and fixed tissue, around the implant. That's key for keeping it clean long-term and preventing issues. Sometimes, we actually have to do grafting procedures to build that up first.
And those little triangles of gum between teeth, the papillae, can we predict if they'll fill in nicely around implants?
That's a really practical question, especially for aesthetics. And yeah, there's pretty good data. If the distance from the bone level between the teeth down to where the teeth actually touch is 4 millimeters or less, you've basically got a 100% chance of having a nice papilla fill that space. But stretch that distance out to 7 millimeters, the chance drops dramatically, down to like 27%.
So initial bone levels are key for that natural look.
Absolutely. And assessing the overall bone volume, well, you can get a rough idea by feeling the jaw, palpation, but radiographs, x-rays are really the essential tool.
Okay, so that's a local picture. But zooming out to stomach health, what about things like smoking or diabetes or even bone conditions like osteoporosis? Do those throw a major wrench in the works?
They definitely can. These are those hidden influences. Cigarette smoking is a big one. It has a really harmful effect. There are studies showing failure rates in smokers can jump as high as 35%, especially if the implant's placed in softer, less dense bone. Compare that to maybe 3% in non-smokers or in denser bone. Interestingly, though, it seems like some of the newer implant surfaces, the moderately roughened ones, might actually perform a bit better in smokers and in that softer bone.
Any other big systemic red flags?
Yeah, radiation therapy to the head and neck is a major one. If the dose was over about 50 gray, it's generally considered a strong contraindication. There's a real risk of something called osteoradionecrosis, basically, the bone tissue dying because the radiation damaged its blood supply and cells. Now, there is an ongoing discussion, quite interesting actually, about using hyperbaric oxygen therapy, essentially breathing pure oxygen under pressure to maybe help reduce that risk.
Right, I've heard of that. What about really common things like, say, controlled diabetes or osteoporosis?
Good question. Things like diabetes, connective tissue diseases, autoimmune conditions, even HIV, they're generally considered relative contraindications. The key word is relative. If the condition is well managed, if the patient's working closely with their medical team, implant treatment might still be a very good option to improve their quality of life. And maybe surprisingly, chemotherapy during the healing phase hasn't actually been shown to negatively impact success rates.
Yeah.
As for osteoporosis, despite affecting bone density elsewhere, there's no clear link showing it's a direct reason not to get implants.
Okay. And back inside the mouth, any other local factors besides bone and gum quality?
Definitely. Active gum disease, periodontal disease,
Yeah.
that absolutely has to be under control first. You don't want active infection around. And then there's bruxism, teeth grinding or clenching, if you're a heavy grinder.
You're putting a lot of stress on that implant.
Yeah.
Exactly. It's like subjecting it to constant tiny earthquakes. That micro movement is bad, especially in softer bone. It stops the bone from integrating properly. And the off-axis forces from grinding can speed up bone loss and cause parts of the restoration to fail. So being aware of it and usually wearing a protective night guard or splint is really important for protecting the investment. It just shows how small habits can have big consequences.
Wow, okay. So much to consider even before you start the actual procedure. We've got the biology down, we understand the patient factors, now the planning. How do dentists actually map everything out to create something that works and looks good?
Right, the planning phase is critical. Before any surgery, we use imaging, like getting that detailed blueprint you mentioned. We often start with traditional x-rays. You have the small periapicals that give a great view of single teeth, root angles, bone levels right there. And then the bigger panoramics, which give you the wide view. You can see the nerve canals in the lower jaw, the sinuses up top, the floor of the nose. Useful overview. But the real leap forward in precision planning, honestly, has been 3D imaging, specifically cone beam computed tomography, or CBCT.
CBCT. I hear that term a lot now. What's the big advantage of going 3D?
Well, it gives you that true three-dimensional picture of the bone and surrounding structures, and critically, it does it with much, much less radiation than older medical CT scans. Plus, the scan time is faster. It's incredibly useful when the bone situation is tricky, maybe not much volume, or when you're working near those big sinuses or important nerves. It's also really good for checking the health of the sinus before you'd even think about doing any bone grafting up there.
Okay, so you get this amazing 3D map, but then I hear about surgical stents or guides. Why are those so important? What do they actually do during the surgery?
They are absolutely essential. You could even say mandated, because once that implant integrates, placing it is, well, permanent and irrevocable, as the text puts it. You can't just reposition it easily. So the stent's job is to perfectly connect the plan where the final tooth needs to end up for biting and aesthetics with the reality of the patient's bone structure. They'll have it like a high-precision GPS for the surgeon's drill. It guides them to put the implant in the absolute optimal spot. Optimal for handling chewing forces, optimal for looks, and crucially, optimal for avoiding hitting anything important like nerves or blood vessels.
So it translates the digital plan into physical reality.
Exactly. And these stents can range from fairly simple, clear templates made in the lab to really sophisticated computer-designed guides based directly off that CBCT scan and a virtual plan of the final teeth. They ensure incredible accuracy.
Got it. So planning's done, GPS is ready. Now we actually build the tooth or teeth. What are the key design principles when creating the restoration itself?
Okay, one really basic but important idea is the crown-to-implant ratio. Ideally, you want the part of the tooth you see, the crown, to be about the same length as or shorter than the implant hidden in the bone.
Mm.
So a 1.1 ratio or less is the goal. You generally need an implant that's at least 10 to 12 millimeters long because the visible tooth part is often close to that anyway. If the ratio isn't ideal, say the crown needs to be quite long, or if it's a tooth taking heavy chewing forces, then splinting it, connecting it rigidly to another implant might be necessary for added support.
And how you bite the occlusion. Are there special rules for implants since they don't have that natural ligament like teeth do?
Yes, definitely different considerations. A big one is trying to minimize sideways or lateral forces on the implant as much as possible. Those aren't handled as well as direct vertical forces. Also, if you're storing a whole arch against, say, a regular denture, you design the bite differently, often aiming for what's called bilateral balanced occlusion to help stabilize the denture. And here's something fascinating. Implants don't have proprioception. That's the natural sense your teeth have that tells your brain how hard you're biting.
So you could bite harder on an implant without realizing it.
Potentially, yes. Studies show maybe patients actually increase their bite force after getting implants, often within the first year. So because of that lack of feedback and potentially higher force, it's really important to design the bite so the main contacts land directly over the implant body, not off to the side. And the overall force should be maybe equal to or slightly less than on natural teeth.
That's a subtle but really important difference. What about the implants themselves? Have the designs changed much over the years?
Oh, big time. We started way back with machined parallel-sided screws, the classic brainmark type. Then came implants with textured surfaces designed to press fit into the bone. More recently, say the last couple of decades, the trend has been towards tapered implant shapes. These often have more aggressive thread designs, what we call macro-retentive features. These help achieve better initial stability when the implant is first placed, especially in bone that's not super dense. And the surface itself has gotten really sophisticated. It's not just smooth metal anymore.
Right, you mentioned roughened surfaces earlier for smokers.
Exactly. Modern implants have surfaces that are precisely engineered at a microscopic level. Moderately rough is the term often used. Think of it like creating the perfect texture for bone cells to grab onto and grow into. It encourages a stronger, faster bond between the bone and the implant.
And what about this Morse taper connection I hear about? That sounds technical. How does that help with things like screws coming loose, which seems like a common issue?
Ah, the Morse taper.
Yeah.
Yes, it's a really clever piece of engineering. It's basically a very precise cone-shaped connection inside the implant that matches a cone shape on the abutment. The abutment is the piece that connects the implant in the bone to the crown you see. When these two tapered surfaces engage, they create an incredibly tight, almost friction-locked fit. It's mechanically very stable. This design drastically reduces tiny movements and stresses being transferred to the little screw that holds the abutment in. And that means much less chance of that screw loosening or even breaking over time. It was a significant step forward.
So it makes the whole connection stronger and more reliable.
Precisely. And those abutments, they're the part that extends up to the gum tissue. They provide the platform for the final crown or bridge and also help shape the gums to form that biologic width we talked about. They come in different materials. Titanium is common, strong, doesn't attract much plaque. Cast gold can be used for a warmer look in aesthetic areas. And ceramics like zirconia are great for aesthetics, especially if the gum tissue is thin and you want to avoid any gray showing through.
And getting all this to fit perfectly relies on super accurate impressions, right?
Absolutely critical. The impression transfers the exact 3D position of the implant or the abutment from the mouth to the dental lab model. We can take impressions at the implant level, fixture level, or after the abutment is attached, abutment level. There's a technique called the open tray impression, where parts of the impression stick out through holes in the tray. It's generally considered more accurate, especially when you're dealing with multiple implants that need to be connected together perfectly. That precision is key for a passive, stress-free fit of the final restoration.
Okay, foundations, planning, the components themselves, we've covered a ton. Let's dive into the actual restoration types. Starting simple, replacing just one missing tooth.
Right, the single tooth replacement. First step is looking at why the original tooth is being lost, maybe severe decay, a root fracture, bad gum disease. Now, when you compare replacing that single tooth with an implant versus a traditional bridge, or FPD, this is a key takeaway. Implant-supported single crowns consistently show the highest long-term success rates of pretty much all implant restorations. They are incredibly reliable. While traditional bridges work well too, they have known potential issues, maybe needing root canals on the neighboring teeth used as anchors, decay getting under the bridge crowns, sometimes the bridge can come loose. So if the patient has enough bone and tissue and the space is right, an implant single crown is really considered the gold standard now.
And if that single tooth is right at the front, in the smile zone, aesthetics become paramount.
Oh, absolutely. The maxillary anterior region, your upper front teeth, that's prime real estate aesthetically. We pay close attention to natural proportions. For example, the side tooth, the lateral incisor, typically looks best when it's about 2/3 the width of the central incisor next to it, and the canine about 2/3 the width of the lateral. There's also an ideal ratio for the width versus the length of the front teeth, usually somewhere between 66% and 80%. These are the kinds of ratios found in naturally attractive smiles. It's about creating harmony. Even things like lip support, especially in patients missing all teeth where a denture flange helps fill things out, contribute to that natural look.
For these single crowns, you mentioned cemented versus screw-retained attachment. Can you break down the pros and cons again?
Sure. So cemented crowns are often favored for looks, especially up front, because there's no screw access hole visible, say on the biting edge. They can look very seamless. The big challenge, though, is getting all the excess cement out from under the gum line after it's seated. Leaving even a tiny bit behind can cause inflammation and bone loss. It requires meticulous technique. Screw-retained crowns, on the other hand, have the big advantage of being easily retrievable. You can just unscrew them for cleaning, inspection, or repair if needed. No cement worries. This makes them often preferred for back teeth. The downside is you need to plan the implant position perfectly so that screw access hole ends up somewhere acceptable, like on the chewing surface, not out on the front face of the tooth.
Okay. Moving on to replacing multiple missing teeth with an implant bridge, an FPD. What's the absolute #1 rule there?
The cardinal rule. Implant bridges must be supported only by other implants. Never, ever connect an implant rigidly to a natural tooth within the same bridge.
Why is that such a strict rule?
Because natural teeth have a tiny bit of natural movement or flex in their socket, thanks to the periodontal ligament. Implants are fused rigidly to the bone. If you connect the two, the natural tooth can actually get pushed down into its socket over time, intrusion we call it. This puts all sorts of weird stresses on the bridge, leading to things like the screw holding the implant part loosening or even components fracturing. It just doesn't work well long term.
Okay, so all implant support is key. What about bridges in the front, the aesthetic zone, or using cantilevers?
For aesthetic zone bridges, doing a diagnostic wax-up, basically a mock-up of the final teeth on a model, is absolutely crucial for planning the tooth shapes, positions, and smile line. Often, some bone grafting might be needed first to build up the ridge if it's shrunk after tooth loss. And again, those spacing rules apply. Keep implants at least 2 millimeters from natural teeth and 3 millimeters from each other. Cantilevers, where the bridge extends off the last implant like a small diving board, can actually be useful sometimes. If there isn't enough bone or space for another implant further back, a small cantilever can work. These are almost always designed as screw-retained frameworks because that structure handles the bending forces of the cantilever better.
Right. Now let's tackle the situation where someone is missing all their teeth, a dentulous patient. What are the implant options there?
There are several great approaches. We can start with implant-retained overdentures. These are dentures that snap onto implants for much better stability than traditional dentures. In the lower jaw, even just 2 implants in the front can make a world of difference in support, retention, and stability. You can use simple stud attachments like little snaps or a connecting bar between the implants. A bar is often better if the implants aren't perfectly parallel or if they're very close together or if the bone quality is a bit poor as it spreads the load better. One practical point. You need enough vertical space for these bar systems, usually around 11 millimeters, for the bar itself, space underneath for cleaning, and the denture material. For the upper jaw, because the bone is often softer and the force is different, you generally need more implants for an overdenture, typically a minimum of 4, often connected with a bar for cross-arch stability. The denture usually still covers the palate for support.
And you mentioned implant-supported overdentures too. How are they different?
Implant-supported ones are for cases with even more severe bone loss, where the denture needs virtually all its support directly from the implants, not the gums. In the lower jaw, this often means 4 to 6 implants placed between the mental foramina, the nerve openings near the chin. This solid base allows for extending the denture further back, maybe with cantilevers up to 10-20 millimeters, covering the chewing area better. In the upper jaw, Achieving full support can be more complex. Traditionally, it might involve 8 implants, sometimes needing sinus lifts, or using specialized longer implants called zygomatic implants anchored into the cheekbone, usually placed bilaterally.
And then there's the option for fixed teeth, the kind you don't take out at all.
Right? The fixed detachable prosthesis, often called a hybrid. Think of it as a very strong metal framework with denture teeth and pink acrylic processed onto it, all screwed securely onto the implants. The patient can't remove it themselves. A big plus is it doesn't have the bulky denture flanges covering the gum, so it feels much more like natural teeth. The trade-off is they require quite a bit of vertical space, usually around 15 millimeters from the implant platform to the opposing teeth, for the framework strength and room underneath for cleaning. And precise implant placement using surgical guides is critical for these.
Okay, we've covered the main restoration types. Let's push into some of the more advanced techniques or specific situations. What about placing implants right when a tooth is pulled?
Yeah, immediate placement. Putting the implant into the socket right after extraction. It has advantages. You tap into the healing potential of the fresh socket, and it can help preserve the bone shape. The key requirements are that the site needs to be infection-free, and the socket walls need to be reasonably intact. There's even a technique where you use orthodontics to slowly pull a failing tooth partly out of the socket over time, which can actually help build up bone and gum tissue before the extraction and immediate implant placement. Alternatively, there's early placement, maybe 4 to 8 weeks after extraction. This lets the soft tissues heal over a bit, gives you more tissue for closing the site, but still benefits from some early bone healing. It can sometimes lead to better initial implant stability too.
That initial stability sounds really important. How stable does it need to be?
It's absolutely critical when we talk about primary stability, how tight the implant feels right when it's placed, its resistance to twisting, and secondary stability, which develops as the bone grows onto it. And here's a really crucial point about healing: micromovement. If that implant moves more than about 50 to 75 micrometers, that's incredibly tiny, less than a hair's width during the early healing phase.
The bone won't integrate properly.
Exactly. Instead of solid bone locking onto the implant, osseointegration, the body forms a layer of soft fibrous tissue around it, and the implant fails. It basically becomes like a tooth with severe gum disease loose. That's why controlling movement is paramount. It also explains why immediately loading an implant, putting a temporary or final tooth on it right away, needs careful case selection. Connecting multiple implants together, especially in the strong bone of the front lower jaw, and achieving very high insertion torque, like over 30 Newton centimeters, makes immediate loading more predictable there. But for single teeth, especially immediately placed ones, the data is less supportive for routine immediate loading. Caution is usually advised.
Makes sense. What about really complex cases, like after cancer surgery, where someone has lost part of their jaw?
Maxillofacial prosthetics is a whole specialized area where implants are truly life-changing. For patients who've had part of their jaw removed, say for a tumor, reconstruction often involves using bone grafts from elsewhere, like the fibula bone from the leg, brought up with its own blood supply. Implants can then be placed into this grafted bone, often getting really good stability by engaging both sides of the graft, by cortical fixation. This allows for fixed teeth, even if the resulting crown-to-implant ratio isn't ideal. For defects in the upper jaw, reconstructing the bone can be harder, so options might include extensive sinus grafting or those zygomatic implants we mentioned, anchored in the cheekbone. They usually need to be placed on both sides for stability.
And outside the mouth, replacing parts of the face.
Yes, craniofacial defects. Implants provide incredibly reliable anchors for attaching prosthetic ears, noses, or eye sockets made from synthetic materials. The bone around the temple seems to be one of the most predictable sites for these implants, even if the area has had radiation before. And bone-anchored hearing aids, BAHAs, are another fantastic application of this same osseointegration principle.
You keep mentioning radiation. Let's circle back to that risk. Why is it such a concern? And you mentioned hyperbaric oxygen.
Right. The main issue with radiation, especially doses over 50 gray, is the damage it does to the bone cells, the osteoblasts, and particularly to the small blood vessels within the bone. This reduced blood supply makes the bone much more vulnerable to breakdown and infection, leading to that osteoradionecrosis risk if it's surgically traumatized, like by placing an implant. However, implants can still be successful in radiated bone. It just requires careful planning and management, and that's where hyperbaric oxygen therapy, HBOT, comes in. By having the patient breathe pure oxygen under increased pressure, you essentially supersaturate their tissues with oxygen. Studies have shown this can significantly improve blood vessel formation and angiogenesis in the compromised tissues, which helps reduce the risk of healing complications after surgery. It actively helps the tissue heal better.
Okay, so even with all this amazing tech and planning, things can still go wrong. Long term, what are the common hurdles and what does maintenance look like?
Yeah, long-term success requires ongoing care. Potential complications can involve the soft tissues maybe not having enough of that tough keratinized gum, or the implant being placed at a slightly off angle, making cleaning hard, or developing deep pockets around the implant, say over 5-6 millimeters deep. Radiographically, we expect that initial bone settling, but after the first year or so, continued bone loss beyond that slow 0.2 millimeter per year rate is a warning sign.
What about the hardware itself? Screws loosening, parts breaking?
Screw loosening is probably the most common mechanical issue, particularly with single crowns, just due to the forces involved. But modern designs, like that Morse taper, have helped a lot. Proper tightening initially, using torque wrenches, retightening after a settling period, and making sure the bite forces are balanced are key preventative measures. If a screw loosens, it usually just needs to be replaced and retightened. Abutment fracture is less common, but can happen, especially if there are very heavy bite forces or maybe an inappropriate material was used, like using certain ceramics in the back where forces are high. Implant fracture itself is actually very rare. The source quotes less than 0.6% failure rate due to fracture. It's slightly more common in smaller diameter implants or in patients missing many teeth, putting more load on the remaining implants. Often, repeated screw loosening or significant bone loss around the implant are warning signs before an implant might fracture.
So, maintenance is key to catching these things early. What does that involve?
Regular checkups are vital, especially in the first year. We do a clinical exam, checking the gums, making sure the implant isn't mobile, often by gentle tapping, assessing tissue health, and radiographic evaluation, usually specific periapical x-rays or sometimes panoramic views to monitor the bone levels over time. Cleaning is also critical. You have to use special instruments, typically plastic, graphite, Teflon, or gold-tipped, that won't scratch the titanium surface of the implant or abutment. Scratches can make it easier for plaque to stick. For screw-retained cases, they might be removed periodically for thorough cleaning, maybe every couple of years. Cemented ones usually aren't removed routinely unless there's a specific problem to avoid damaging them.
Okay, so after all that, the complex surgery, the careful restoration, the ongoing maintenance, how do you actually define success? When can you say, yes, this implant worked?
That's a great question. The classic criteria go back to Albrechtsen and his colleagues. They focused on objective measures. The implant must be immobile when tested clinically. There should be no evidence of a dark halo or radiolucency around it on the X-ray, which would indicate fibrous tissue instead of bone. And importantly, there should be no persistent pain, infection, numbness, or nerve problems associated with it. That bone loss rate should also stay within those very slow limits after the first year. Those criteria are still fundamental. But later on, like at a big consensus conference in Toronto back in '98, they added a really important dimension. Success also means the implant is supporting a functionally aesthetic restoration.
So it's not just about the implant surviving in the bone. It has to actually do the job it was meant to do, look good, and chew properly.
Exactly. It bridges the biological success with the patient's actual experience and outcome, and assessing that mobility part. Besides tapping, there are devices like the period test or newer radiofrequency analysis tools that can give a more objective measure of how well that implant is integrated with the bone.
Wow. This deep dive has really peeled back the layers on dental implant prosthodontics. It's so much more than just replacing a tooth. It's this incredible intersection of deep biology, understanding the whole patient, meticulous engineering and planning, and yeah, real artistry in crafting the final result. It's constantly evolving too.
It really is. And I think what this deep dive shows is that it's not just about, putting a metal screw in bone.
Yeah.
It's about creating this harmonious, integrated, almost living system within the body. And that, I think, raises a really interesting question for the future. As we understand more about the body's own amazing healing and regenerative capabilities, how might that continue to change things? Will we move beyond needing metal implants altogether someday?
That is a fascinating thought to end on. Where could this technology go next? We hope this discussion has left you feeling much more informed about the incredible detail and care that goes into modern implant dentistry. Thanks for diving deep with us today.